like open slide? Yeah.
Yep, it looks good.
Do you want me to stop sharing while people join?
Sure, that's fine.
Okay.
I'll actually
researcher in the Johns Hopkins University School of Medicine, Division of Geriatric Medicine and Gerontology, with a joint appointment in the Department of Health Policy and Management in the Johns Hopkins Bloomberg School of Public Health. Dr. Nothelle is a board certified in internal medicine and geriatric medicine and practices as a geriatric primary care physician and internal medicine hospital attending at Johns Hopkins. She's a current recipient of an NIA K23 Career Development Award focused on understanding and improving care delivery for older adults with complex care needs. Thank you so much for being here today, Dr. Nothelle. I'll let you take it away.
Thank you. Thanks so much for that introduction. And thank you so much for hosting me with you all. And I really hope that my talk isn't just me kind of talking at you, but hopefully we'll bring up some good discussion and conversation at the end. So I'm going to try to share my slides. My computer is a bit geriatric itself, so sometimes it takes a minute. Hopefully you're seeing my title slide. Someone please let me know if you're not. So as Dr. Bradley said, I'm going to be talking to you today about improving care delivery for persons with dementia and chronic medical conditions. I have no disclosures. So as was said in the introduction, I'm a geriatrician and primary care physician, and I'm really motivated in what I do in my research by the patients I care for. I think it's probably true of many of us that the research that we do is meant to make things better for the people we take care of, whether that's, our patients or ourselves or our families when we become patients. So I wanted to start the talk by presenting a patient example. This is a hypothetical patient, although based on real clinical experience that I recently had. So this is Mr. Smith. He is an 85-year-old man with dementia and diabetes on insulin, complicated by peripheral vascular disease. He's had to have a couple of significant procedures for his vascular disease. He also has chronic kidney disease, stage 4, and hypertension. He takes 10 medications, including insulin. He lives with his adult daughter, who helps him with most of his independent activities of daily living, including managing medications and scheduling appointments. In terms of his medications, she will give him reminders like, hey, Dad, time to take your insulin, time to take your blood pressure medication, whatever it is, but then he administers it himself. And she does work full time, so she's not always able to attend appointments with him, but relies on the patient portal, which at our institution is called MyChart, where she always looks at the visit notes and the after visit summary to make sure that she's kind of helping her dad stay on top of things. So we're just going to walk through some recent clinical encounters for our hypothetical patient, Mr. Smith. So as I mentioned, he has dementia and diabetes. He was seen by his endocrinologist, and his A1C was noted to be a little bit elevated at 9. And his endocrinologist wanted that number to be a little bit lower, so intensified his insulin regimen. Mr. Smith was doing okay with that for a couple of months, but then he developed an upper respiratory infection and wasn't eating and drinking quite as much. In that setting, he was also kind of a little bit more sleepy, not thinking quite as clearly, and was forgetting to measure his blood sugar, and was just kind of going about his medications as he normally does. In that setting, he was taking his usual doses of insulin, and as many of the clinicians who are listening to this can probably guess, started having unrecognized episodes of hypoglycemia. And in this setting, he became unsteady. His daughter, not realizing that the hypoglycemia was going on, just noticed that he was unsteady and called the primary care office, which unfortunately didn't have any appointments available. And so he was referred to urgent care, where he saw a provider he's never seen before who said, oh, you have an upper respiratory infection, COVID's running rampant. This was several months ago. Why don't you, we'll give you a COVID test. You should rest and take some over-the-counter medications. The diabetes was really not discussed at that visit. He goes home. COVID was negative, was told to take some Tylenol and some Robitussin. And unfortunately, the next day had a fall with a laceration, went to the emergency department visit, had the laceration taken care of. and was sent home. While he was in the ED, his glucose on his BMP was 72, but it wasn't mentioned, potentially because the lower limit of normal on the hospital system glucose is 70. So 72 was not flagged as being out of range. He was told to follow up with his PCP, scheduled an appointment for like a week later, but never made it to that appointment because a day or two after that, he fell and he broke his arm. He was hospitalized and his A1C was now 6.4. So, for clinicians, this story probably sadly isn't that crazy or surprising. No clinician committed malpractice. Mr. Smith just kind of went through the healthcare system that we all know has many inefficiencies and really works better as individual pieces than as a whole. While there isn't one solution or intervention that would make everything better for Mr. Smith or, in general for situations like these, it's my current career ambition to try to identify a pragmatic way, or more likely pragmatic ways, to improve upon our status quo. So this is kind of my guiding question for my work right now. And so we'll come back to this slide throughout the talk as I walk you through kind of some of the projects I've done and how I'm using the results I've found to inform the answer to this question. So for the rest of the talk, we're going to discuss 3 different topics. First, we're going to talk about if I want to improve care for a population of people like Mr. Smith, I need to be able to define that population. So we're going to look at the heterogeneity of complexity and dementia and kind of how I've approached that using the lens of serious illness. Then we're going to talk about current models of care delivery for the population of older adults with dementia and chronic illness, namely care management, and how we can leverage and build upon what already exists. And then lastly, we'll tie everything together and talk about some next steps. And that's where I would welcome your ideas and discussion about how we could work together or projects that you all are doing in this area. Okay, so first up, examining the heterogeneity of complexity in dementia. So there's lots of different ways that, I could define or approach complexity, but one that stood out to me as a primary care clinician is the intersection of dementia and other chronic medical illnesses. I have found in primary care managing chronic medical illnesses and often multiple chronic medical illnesses really challenging. But when one of those chronic illnesses is dementia or cognitive impairment, I feel like the complexity of care is really uniquely challenging. So as I was thinking about this a few years ago, I was introduced through my primary mentor to Dr. Amy Kelly. She's a geriatrician and a palliative medicine physician who has, through her work, advanced the science of identifying and measuring complex medical illness by defining and operationalizing a definition of serious illness for use in administrative and claims data. So I had the opportunity to work with Dr. Kelly on a project looking at how her definition of serious illness could be used to examine the heterogeneity of complexities in dementia care. So Dr. Kelly, through consensus work with leaders in the field of palliative medicine, has defined serious illness this way, which is that serious illness is a condition with a high risk of mortality that negatively impacts function or quality of life or excessively strains caregivers. Dr. Kelly further defined that this definition can be broken into 3 main manifestations in older adults, and those are activity of daily living impairment, advanced medical conditions, and dementia. Activities of daily living and dementia are probably pretty self-explanatory to you all, but what about advanced medical conditions? How could you capture with routine administrative or claims data that a condition like diabetes has reached the point where it meets this conceptual definition on the slide? Dr. Kelly's group accomplished this by being very specific in the diagnoses they used and using additional claims criteria to try to capture an advanced form of a chronic condition. So on this slide, I listed the 6 most common advanced medical conditions. There's a much longer exhaustive list that I'm happy to share with anyone who's interested. But for the sake of space and time, I'm just focusing on some of the more common ones. So, while you might think of chronic kidney disease as a common chronic condition, to be an advanced medical condition, the way Dr. Kelly has operationalized things, you have to have an ICD code for chronic kidney disease stage 5 or end-stage renal failure on dialysis. Similarly, chronic obstructive pulmonary disease, a common chronic condition with a lot of heterogeneity in its severity. To be considered an advanced medical condition by this definition, you either have to have an additional claim for home oxygen use or have an admission where the reason for admission is exacerbation of your chronic obstructive pulmonary disease. And so on. You can read the other examples on this slide. So, I think that the take-home message is that this is identifying a population that is really, really quite sick. So Dr. Kelly kind of did this foundational work and published a series of articles showing that her definition captured a very high need and high cost population. But in her work, it wasn't clear if these things intersected at all, and if they did, how frequently and with what implications for patients, family, and society. So getting back to my own goal of improving care for the population of older adults with dementia and complex chronic illness, I wondered specifically about the overlaps of these other manifestations of serious illness with dementia. And if using this lens would allow me to capture kind of an actionable cohort of complex persons with dementia. So with this project that I did, I asked, how often do these manifestations of serious illness, so ADL impairment and advanced medical conditions, co-occur with dementia? And then what are the implications of the different, resultant combinations of things for health services use and also for caregiving intensity? Okay. So to answer this question and to get a better sense of, who is captured in this population, we used the health and retirement study data linked to fee-for-service Medicare claims. The health and retirement study is a nationally representative survey of older adults in the US. Older adults who are included in the sample are surveyed every other year. And then you can link for the majority of participants in HRS, you can link their survey responses to Medicare claims. So we took the survey responses from 2016 and linked them to 12 months of, like I said, fee-for-service claims, pre and then post. In the 12 months pre, we identified our populations of interest. So those different serious illness groups that I mentioned in the circles on the other slide. To identify ADL impairment, we looked at survey responses indicating a need for assistance with activities of daily living. For advanced medical conditions, we used claims-based ICD codes, as I shared. And then for dementia, we used one of the validated approaches for identifying a population of older adults with probable dementia. For those of you who work with HRS, the one that we used was by Hurd et al. And for those of you who have no idea what I'm talking about, basically that means that we identified people with dementia not by whether or not they had an ICD code for dementia, because that really just captures the people where the doctor typed in the code, and we know that it's often undercoded in healthcare, but rather this probable dementia approach uses cognitive test results as well as self-reportive dementia diagnosis in a fancy statistical model that predicts that someone has a high probability of having dementia based on their cognitive test scores. Okay, and then in the 12 months post the interview, we measured a number of outcomes. So in terms of caregiving, we looked at average monthly hours of paid and unpaid caregiving support. And then for health services use, we relied on Medicare claims to look at emergency department visits, hospitalization, and total Medicare costs. Sorry, I'm having some trouble advancing my slides here. There we go. Okay, so this is kind of the landscape of the population that we included. We used the HRS survey provided weights to project national estimates. So HRS doesn't actually survey, millions of people, but provides you with weights that you can use to kind of project how many people those survey respondents represent in the US. And so you can see we identified, an estimated 2 million older adults with dementia. And then, as I mentioned, we were interested in kind of these overlaps. So of the 2 million people with dementia, you can see that about 30% of them have, only dementia. When I say only dementia, that doesn't mean they don't have other chronic conditions, but they don't have, dementia and ADL impairment or dementia and advanced medical conditions. And we can see 45% of the population of older adults with dementia, just shy of 1 million older adults, have dementia as well as ADL impairment. And this 45% represents this kind of three-pointed figure that I'm tracing here in the Venn diagram. So just the overlap of dementia and ADL impairment, not including the advanced medical conditions. And then lastly, about a quarter of folks, 24% in total, have dementia and an advanced medical condition. The majority of whom, so 16% of the 24%, have an ADL impairment as well. Before we move on to our table 1 with demographics and our outcomes, I just want to briefly orient you to the groups, the way we divided up the population to make comparisons. As a visual person, I find it easier to kind of point it out visually. So, first we looked at kind of all comers with dementia, so everyone represented in the light blue circle. And then we looked at 3 mutually exclusive groups. First, the 30% of older adults with dementia, quote unquote, alone. The 45% of older adults with dementia and an ADL impairment, but without advanced medical condition. And then the 24% with dementia and an advanced medical condition, right? That includes people both with and without ADL impairment. Okay, so here on this next slide, you can see those 4 groups that I just oriented you to. And this just kind of displays some of their demographic, socioeconomic, and functional criteria. And what you can see is that it's a relatively old group, right? Mean age across the board is mid to upper 80s. Majority female, which is not surprising. But what I'll draw your attention to is this column here, the dementia and advanced medical condition group. They are slightly different than the other groups, right? So slightly less likely to be female, slightly less likely to be non-Hispanic white, less likely to have more than a high school education, really significantly worse self-rated health. So 70% of people in this category had fair or poor self-rated health, many more chronic conditions on average, and a pretty high proportion of functional impairment. So, this population of older adults with dementia and advanced medical conditions are perhaps more diverse in terms of their gender, race, and ethnicity, and also, potentially a little bit medically sicker. Now switching gears to look at some of our outcomes. Here you see those 4 groups, and then I threw an extra column in there. I hope it's not too confusing. I just wanted to provide kind of like a benchmark, looking at the healthcare use of an older adult with no serious illness. Again, just as kind of a point of comparison, a benchmark for you all. Again, I'm going to draw your attention to this column of dementia and advanced medical conditions because they do kind of stand out in terms of their healthcare use. So you can see slightly more likely to have an emergency department visit, more likely to have a hospital admission, more days in the hospital, right? So about double that of those with dementia and an ADL impairment. And then significantly higher Medicare costs. So whether we looked at the mean in this darker blue row or the median in the lighter blue row, you can see that the costs are significantly greater. about $10,000 greater than the average person with dementia when we looked at the means, or more than twice as great than the average person with dementia if we looked at the median. Okay, but we do know that most of healthcare doesn't occur within the walls of the hospital or the clinic. So we also were interested in looking at average hours of paid and unpaid caregiving assistance and how they differed amongst these groups. And so again, you'll see our 4 groups along the left-hand side. The dementia group that's below this blue bar is kind of the whole circle of dementia. And then the 3 groups above the bar are the mutually exclusive categories. The orange shading indicates hours of help from paid helpers. It's a mean over a month. And then the green bars are hours of help from unpaid helpers. Again, it's a mean over a month. Across the board, you can see, unsurprisingly, most of the hours of help are from unpaid helpers. That's, unfortunate, but not surprising. And then again, you can see that those older adults with dementia and advanced medical condition require the most hours of help on average per month. And they tend to have kind of like slightly less paid help proportionally than older adults with dementia and ADL impairment, but about the same as the total dementia group. Okay, so what did I learn from this work, and what am I hoping you'll take away from this study that I just shared? One is that I was kind of surprised that about 1 in 4 persons living with dementia had an advanced medical condition. I think the claims-based codes for advanced medical conditions capture such a sick population. I thought the prevalence was going to be lower because I thought mortality would be so high that people wouldn't really live long enough with both of those things in existence, but it's a pretty sizable population. The Alzheimer's Association estimates that, I think they say 6 million older adults in the US with dementia. So, a quarter of that is still a pretty significant population of older adults who are living with not just dementia, but also significant medical illness. And then in terms of, again, thinking about interventions, advanced medical conditions, when they co-occur with dementia, are really associated with pretty high healthcare costs. And also from the patient and family standpoint, really a lot of caregiving intensity. So, bringing this back to my guiding question, how do I use this to move the needle forward to improve care for people like Mr. Smith? So working towards, some kind of intervention. The thing that I really took away from this is that, most interventions to be successful and sustainable need to have an economic benefit to payers or health systems. Older adults with dementia and advanced medical conditions accrue a lot of costs. And so there's a lot of opportunity there potentially to try to improve and lower costs and have some cost savings that might be attractive to payers or health systems. But in order to do that, how would I do that? What would my approach be? And so the next thing I found myself wondering was, I don't need to reinvent the wheel, right? There are many people much smarter than I who have been working in this field for a long time. And so what have they found? What do we know already about the current care delivery experience for people with dementia and chronic medical conditions? Well, I don't have my own data to share with you on this topic yet. I hope to very soon. I'm going to share some work from others who, basically the punchline is that status quo care is simply not, as one author put it, dementia aware. The data on this topic is largely from qualitative studies, so studies where they talked with persons living with dementia, their care partners, their clinicians, about what their experience was like having their non-dementia chronic conditions cared for. And so, what we know is that there's an element of what I call, literal awareness or literal unawareness, which is that several studies have pointed out that non-dementia specialty providers, so cardiologists, ophthalmologists, endocrinologists, just don't know that a person who's coming in to see them has a dementia diagnosis or cognitive impairment. So it's hard to accommodate or account for that when you don't know that it's there. And then there's also a lot of figurative awareness or unawareness. We know that older adults with dementia rely heavily on care partners to manage their care, but we don't really do a great job of incorporating care partners into routine care. If someone's sitting next to my patient in the office, I will, of course, talk to them, but I don't think systematically we have a good way of identifying and reaching out and including those people if they're not right in front of us. Care is not very nimble or responsive to changes in cognition. So, we know that, persons with dementia, when they get an acute illness or, they're in pain, something happens, there can be these changes in cognition, but our care plans don't adapt very quickly. And then lastly, there isn't a huge evidence base, right, to say, oh, if you have dementia and heart failure with reduced ejection fraction, Entresto doesn't work for you. Or I completely made that up. I'm sure cardiologists would be very angry to hear me say that. But the point is that there isn't an evidence base for a lot of these decisions. And so, clinicians are doing the best they can and try to adapt the plan for the person in front of them. But that takes time and effort and knowing the patient as a person. And, in the short healthcare visits that we often have, it's just, quite frankly, not always feasible to do that. So if that's the status quo, is there a gold standard? And I think there are lots of models of collaborative dementia care. I should say that the three logos that I put on the side here are not the only three programs. They're just the three logos I could find online. So please forgive me, there are other programs. But while these programs have many differences in terms of the specific types of clinicians that are involved or their specific protocols, they're all somewhat similar in their approach. And so this chart or table from an article by Malaz Bustani from Health Affairs kind of summarizes the typical approach. So these collaborative dementia care models are basically a model of dementia care management, right? So either a clinician, so that could be an advanced practice provider like a nurse practitioner in the UCLA dementia care model, or a dementia care coordinator who doesn't even have a clinical license, which is in the Mind at Home program. The team does a cognitive assessment and comes up with a care plan. They recommend a number of psychosocial interventions, provide self-management tips, medication management tips, treatment of related conditions, and coordination of care. It's hard to read the small print on this slide, but one thing that I will point out to you is that if you read the descriptions of each of these, you'll see that kind of each of these domains is really focused specifically on the dementia. And so even for treatment of related conditions, it says take steps to prevent and treat conditions related to Alzheimer's disease and related dementias, such as depression and delirium. So the focus, is really on the dementia and not, related conditions that are outside of the dementia, such as diabetes or heart failure or kidney disease, which we see commonly co-occur and with significant implications. So before we go too much further into the promise of these dementia care models, I'm going to take a short detour briefly to discuss a project that I started when I was a geriatric medicine fellow focused on care management for complex adults. Like I said, this is a short detour, I promise. I've not completely gone off the rails. It will all tie back in together. And please forgive me while I grab a tissue. I was at the Society for General Internal Medicine meeting last week, and I caught an upper respiratory infection. Okay, so I mentioned that the models of dementia care on the previous couple slides ago were models of dementia care management. But what does that mean? What is care management? So care management is a population health strategy aimed at, quote unquote, high risk patients that could be defined a number of ways, with the goal of reducing unnecessary utilizations, AKA cost, and improving patient self-management, chronic disease control, and coordinating care. In practice, what that looks like is there's usually a nurse or a social worker who's working with one-on-one with this panel of high-risk patients. You might have a care manager in your primary care office. I know we have one in our geriatric primary care office. So when I was a fellow, I kind of surveyed our health system and neighboring health systems to figure out where care managers work for us locally. And the answer is really across the healthcare spectrum. This slide is very wordy on purpose, that, it didn't matter where I looked, primary care, specialty care, hospital, skilled nursing facilities, there was a care or case manager really everywhere. And so if you're an older adult who has complex health and social needs, or, dementia and a complex chronic illness, you're likely to interface with a couple of these different entities. And so it's not hard to imagine that you might end up with more than one care manager, but potentially no one to manage the managers. So here's an example of how that might play out from my own patient panel. This is a patient of mine, let's call her Miss B. And she had the following interactions with the healthcare system over a year. So she was hospitalized with an exacerbation of heart failure, went home with home care, was doing well at home for a little bit, and then had another exacerbation of her heart failure. This time was a little too debilitated and went to subacute rehabilitation, and then was finally back home. Which is when I finally had a chance to catch up with her. And she said to me, Dr. Nothelle, there's all these nurses. They keep calling me. They've been calling me ever since I went to the hospital, way back here in the beginning. Who are all these people? What do they want from me? And so I looked back through her chart and talked to some people and found that, so she had case managers. These are, common in the hospital. And there's also a case manager assigned to an episode of home care. And, these, in all of these cases, these were nurses, are focused on a specific task, discharge planning or in home care, kind of coordinating all the moving pieces of home care, the skilled nursing, physical therapy, occupational therapy. But layered on top of that, she also had a nurse transition guide from the hospital who was charged with following her for 60 days to try to prevent readmission. Since she had heart failure, she was in the heart failure clinic, and they had a, quote, nurse navigator, although the title is different. The role is really one of care management, focusing on chronic disease self-management and care coordination, again, with the goal of keeping her out of the hospital. She was again followed by the transition guide after this last transition. And after all of this healthcare use, her Medicare Advantage plan said, hey, wait a minute, this is a high utilizer, and assigned her a care manager. So what exactly is all of this? Is this helpful or not helpful? And so this led me to ask, what is the experience of care managers, older adults, and care partners with receiving multiple care management services? To answer this question, I designed and conducted a qualitative study of what I called co-occurring care management, receiving care management from more than one source. And we interviewed 37 care managers, 15 older adults, and 13 caregivers, both in the Baltimore metro area and in a rural area of Maryland on the Eastern Shore. We conducted semi-structured interviews with, each of these parties with their experience having more than one care manager. And then we analyzed the interview transcripts using a grounded theory approach, and each transcript was analyzed by 2 independent coders. And so our themes really kind of grouped together into 3, buckets or categories that I'll briefly run through. First was contributors to co-occurring care management. Next were the implications of co-occurring care management. And then lastly were the strategies that the people involved took to deal with having multiple care managers. So in terms of the contributors, older adults and caregivers didn't have too much to say about this. They just felt like they were sick and accessing care a lot. So of course they needed a lot of help. And so most of these themes came from the perspectives of care managers who said, look, our organization faces a specific financial incentive. We have to check these boxes. We have to prevent readmissions. And so that is what my job is. But because we are so fragmented across the healthcare system, Each entity with its own individual financial incentive was creating its own program without, kind of looking already to see what other programs existed and trying to work together. The implications were both positive and negative. Again, older adults were kind of pleased that people were reaching out to them and cared about them. People who were socially isolated appreciated the extra points of contact. Care managers expressed that they sometimes felt like they were duplicating work of others, and that was frustrating. But they also pointed to a positive that was also voiced by older adults and care partners, which is that if you had two care managers with two different skill sets or from two different agencies that had access to different resources, having both of them together could really provide more complete or comprehensive care. In order to get that complementary care, right, the care manager said, well, then you have to identify the other people and try to align your roles. But there was no systematic way to do that. And so they had to employ a bunch of workarounds, kind of emailing, phone calls outside of the electronic medical record in their usual systems of clinical care. So putting it all together, from this study, I learned that, we have systemic structures that are impeding collaboration, these independent financial incentives, and, the siloed, classic medical siloed approach. But that there are opportunities for some of these overlapping services to be complementary and more beneficial to older adults, but that the current system required kind of workarounds, dedicated persons, and their willingness to contribute their time to make that happen. One last point that I want to make that came from some of the quantitative, we asked each person we interviewed, each of the care managers, that is, how long their program typically works with older adults. And most of the programs worked with older adults for less than 6 months. So most of these programs tended to be pretty short. And so although most of the examples that came up in the interviews were overlapping, two care management sources at the exact same time, what's probably much more common is that they're sequential because they're each so short. Okay, so like I said, that was a detour, and now I'm going to bring it all back together, I hope. So coming back to our guiding question, right? So if we know that the current kind of gold standard or the best models of care that are being disseminated for older adults with dementia are these dementia care management programs. But my own work shows that older adults with complex care needs are being targeted quite a bit by care management programs, and that, a potential key to success, particularly for people with, complex needs or differing needs, is that there needs to be collaboration across all of the parts involved. How do we do that? So within our own health system, or not our own, the health system that I work in, we are implementing the Mind at Home model. And so this has led me to wonder, is there a way to integrate it into our healthcare system in a way that improves care, not just for the immediate dementia care needs, which are the primary, focus of Mind at Home, but also in a way that it focuses on the other medical illnesses, with a dementia lens, being dementia aware. Because we know that it's those other medical illnesses that are really driving the healthcare costs, healthcare utilization, and caregiving burden. So to me, that is the question, right? How do we integrate these new models in a way that accounts for these other chronic conditions? And again, there isn't one answer to this, and it'll probably take multiple approaches and failures and iterations. But let's just take a moment to reflect again on Mr. Smith's story to come up with some, potential ideas. So in full disclosure, this is based off of someone where I was the internal medicine attending here at the end when he was hospitalized for his broken humerus. And his daughter was just so devastated and felt like she had failed as a caregiver. Whereas I felt that we had failed as a healthcare system in really helping her as a dementia caregiver. So I spent some time just kind of looking back through his chart and reflecting on, what happened and what we could do to make things better for Mr. Smith and his daughter. So, the endocrinologist didn't really know that Mr. Smith had dementia. It wasn't in his note. Looking at his, problem list. So in our healthcare system, we have a problem list of all the chronic conditions. Dementia wasn't on there, even though the primary care provider had it in their note. So, maybe more awareness about that this patient has cognitive limitations would have resulted in a different approach. I'm not sure. The daughter said, it never occurred to me, no one ever told me that hypoglycemia could present as unsteadiness. And she felt that, maybe she should have just known this. But I felt like maybe we could have done better to provide her with anticipatory guidance. When Mr. Smith went to the urgent care, again, the dementia is not mentioned in their notes. Their notes are quite short. Maybe it was a huge point of discussion. I'm not sure. But again, I wonder if the provider knew that there were cognitive limitations, if that would have changed their frame of mind at all. So again, maybe there's opportunities within the healthcare system to make it a little bit more noticeable that someone has dementia. And then, I think we could come up with a whole laundry list of other issues. Could there be a more comprehensive geriatric approach in the ED or, so on and so forth. But one other thing that I want to mention kind of before I wrap things up is that in talking with Mr. Smith's daughter, something that she mentioned to me that really stuck with me is that she really, she isn't able to attend every appointment because she works full time, but she really relies on the patient portal. And I thought, is there an opportunity there? I'm lucky enough to be part of a project, a group at our institution where we're looking at patient portal use among older adults with dementia. And we wrote this paper that's coming out in Alzheimer's and dementia care soon. And, we found that, so we looked at about 50,000 primary care patients in our system, and we looked at whether or not people living with dementia were just as likely to be portal users or not, to think about kind of, could we use the portal as a tool to reach this population better? And we found that people with dementia are just as likely to be using the portal, but the person who's actually using the portal, so we did an analysis of the messages that were sent. The person actually using the portal isn't the patient themselves, but in most of the cases, actually a care partner. So this has led me to wonder, as I'm continuing to brainstorm, how do we make care better for people like Mr. Smith if we can leverage the patient portal in some way to improve chronic disease self-management and care coordination, right? Is there a way that, as we have these dementia care coordinators entering our healthcare system as part of the Mind at Home project, are there portal-based tools that they can create that can carry on with the person, whether that's anticipatory guidance for their other chronic conditions, whether that's information that they can show at other health systems about their loved one's baseline cognitive status. I think there's lots of possibilities there. And I'm not sure that I, as the clinician, am the right person to know exactly what that thing is. So to figure out what exactly that thing is, that thing being what exactly my intervention will be, I'm going to take the following next steps. So right now I'm leading an analysis of clinical notes and patient portal messages leading up to hospital admissions and ED visits. So we looked back 30 days from a hospital admission or ED visit, and we're doing a qualitative content analysis of the clinical notes and patient portal messages from the outpatient setting to see if we can identify any pain points that might be intervenable upon to prevent the hospital admission, with a focus again on chronic disease self-management and care coordination. Then we're going to use kind of a user-centered design type approach and prioritize our pain points by talking to key stakeholders about their opinions about these things that we've found in qualitative interviews and focus groups, ultimately leading towards a pragmatic intervention. And then, last but not least, pilot testing said intervention. So with that, I wanted to thank certainly I have two wonderful primary mentors here at Hopkins, Cynthia Boyd and Jennifer Wolf, who've given me so much of their time and knowledge. And I've had the benefit of working with a lot of other wonderful colleagues. A lot of people participated in my qualitative study, and then I've been lucky enough to get a number of grants from the National Institutes on Aging to support my work. So I'm very appreciative to all of them, and also appreciative to all of you if you're still awake and listening to me. So I'll stop there because I'd love to hear your thoughts. I'm going to stop sharing my screen if that's okay. Because I can't do the chat and share screen at the same time. I'm not cognitively intact enough to handle that.
Thank you so much. Thank you so much for a great talk. There's some great comments in the chat. When you do have a chance to look at it, I think it really reflects a lot of people having similar experiences. Does anyone have any questions?
I mean, I guess picking up, Linda, if you don't mind me sort of picking up what we were talking about, was this idea about, our healthcare system is, of course, optimized to deliver medical care. And I'm not quite sure what to call sort of more supportive care. And would love to sort of know your thoughts about, do you feel like things are getting oriented towards providing kind of the more practical care, the care navigation that Linda talked about, and I talked to a family about on Wednesday, but that's sort of outside of the medical system, and if people have the means to afford like an independent, coordinator or advisor.
Yeah, I think about this all the time, and I'm not sure. So what I think you're right. Like traditionally, the hospital and the medical clinics provided medical care, but now that there's all these value-based payment models, I noticed like our own primary care clinic this year, we've entered into, and I'm sure I don't understand the nuances of this, I will be the first to admit that, kind of a higher risk model where we are more accountable, and the more accountable we get, it seems like the more we branch away from just the medical care and into the supportive care, because we know that these things have an influence, but there's still, it seems, and of course there's growing pains with everything, but there's still a very strong tension, right, between like what is our role in the medical system versus what do patients and families need. And hopefully the way to tie that together is that I think by giving patients and families what they need, we might be able to save some money, which is what the healthcare system cares about. That's a long way of saying I'm not really sure, but I think about that tension all the time. And if you have more thoughts about it, please, or if you think I'm totally wrong, please tell me.
I should say, Sarah, can we have people introduce themselves too? Because I realize not everybody's going to be from Northwestern and know anything. So I'm Jeff Linder. I'm the Chief of General Internal Medicine at Northwestern. And I apologize to Sarah Doyle, who had her hand up like a good citizen, and I just barged in.
Yes, Sarah Doyle, go ahead.
It's totally fine. There's different Zoom protocols. 3 years in, like you realize it uses a different protocol. My name is Sarah Doyle. I actually did my neurology residency at Northwestern from Chicago. So really excited to join this talk. I'm up at the University of Wisconsin now doing fellowship in general public health and preventive medicine with like a strong interest in like how do kind of twofold, both like how do we incorporate more prevention into neurologic diseases? I think there's strong evidence that that's possible, but then also too, like for people who have dementia, which is a growing number, like how do we care better for them? And also, with a practical lens of like controlling costs too. And hopefully that's like a win-win situation, because there's definitely plenty of data that say, look, when people with dementia get hospitalized, they really do poorly. Like it's a big loss for them after they get discharged. But my question is, I guess practically with the mind at home, I know there's, like you said, there's so many different models and things out there. Do you, at Johns Hopkins, are they evaluating it periodically? And if so, what outcomes are they looking at? Are they looking specifically at its impact on like hospitalizations? Is it more like other kind of patient-specific, caregiver-specific outcomes? Because a little bit of context, it seems like it's been really challenging for these care coordination models to actually have an impact on healthcare use or hospitalizations at least. And that might just be because we have limited tools to study it. Oftentimes it's small, or they're like, oh, we didn't have access to like half these people's records anyway, so I just wondered if that's built into implementing it is like an evaluation plan, and if so, what you're evaluating.
Yeah, I wish I could tell you exactly. The truth is that I am not part of that decision-making group. I am hoping to take, I'm trying to think of a better way of saying this. I don't want to take advantage of, benefit from, leverage. What's the positive spin on that? It's an opportunity for me as someone who's interested in improving care coordination. So I'm very interested in learning more about how the health system is doing it, but it's being done by our care transformation organization, which is basically within our Office of Population Health. It was being provided by Hopkins previously as a fee-for-service model. So families that could afford it could pay for Mind at Home, and now our care transformation organization is going to fund it for people who are in our comprehensive primary care program. I don't know exactly how they're going to measure quote unquote success. I would assume that cost and utilization are the main outcomes that they're interested in. But because that's like a health system project and not a research project, I'm more connected to the research side of it. Like Quincy Samus is the PI who came up with and disseminated Mind at Home. And so, know her and collaborate with her, but this is more of a health system intervention. Sorry, that's like a very non-answer answer.
Totally fine. Thanks. Thank you.
And actually, I'm aware that there's pretty good literature for disease-specific care management. So CHF, COPD, diabetes, but sort of as soon as things get complicated with like free range older adults, I actually don't know if anybody else on the call does. I don't know of anything that has shown that these care management for exactly the type of patient you're talking about, Stephanie, that they're cost effective and or effective.
Yeah, that's kind of my bent. I love the phrase free range older adults. I just feel like so many of these models have like a really nice JAMA or whatever journal article proving their efficacy. And then when they're implemented, it doesn't pan out in the same way. And I think that's because people are more complicated than just having CHF or just having diabetes. And that's why I love geriatrics. And that's what like frustrates me, that I want these programs to be kind of more open to the realities. So that's going to be my life's work, I guess. But if people know more about that, I'm always all ears.
Is there another question?
Yeah, Rick Frutinsky here. I'm from the UConn Pepper Center, and how are you, Stephanie? That was a nice integration of a lot of different strains of research. And Jeff, thanks for notifying me about this talk 15 minutes before our Pepper Center directors meeting ended. So I'm glad to be here. Really, two questions. Quincy must have heard from you already that you might think that the Mind at Home intervention lacks attention to other chronic conditions. And I'm wondering, is she actually thinking of modifying or adding to what exists already that's more dementia specific information for patients and families if they have, in addition to dementia, other advanced medical conditions? Is that a strategy she's considering? And if so, would you find that useful? That's the first part. And then I'll just kind of mix the other one in, which is the patient portal based strategy idea you have. And I was just wondering if you were thinking of using the patient portal as a way to link patients and families with any of these care management interventions, or were you thinking of something different about a way to use the patient portal to address the gaps that you see? in this population? So it's two questions, I guess.
Yeah.
Either one is okay.
Two great questions. I'm certainly very familiar with your work, so thank you for attending my talk and paying attention enough that you have questions. I'm very flattered. So I have met with Quincy several times. She's very nice and a very collaborative person. I think if I came to her with something, she'd be willing to hear it. I don't have a thing yet to say, so it's hard to ask her to commit to something when I don't have, something concrete, but she's always been nothing but, collaborative and warm and welcoming and wonderful. So I think that there's potential there, and what you described is exactly right. I wonder if, if we have someone with a dementia care coordinator through the Mind at Home program working with one of these older adults, if we can utilize their expertise to kind of implement some of these things. But the question is, what does the specialty care provider need to know and what would be helpful? So that's what those are some of the pieces I need to figure out. In terms of your second question, yes, I do think that the portal can connect people to resources. I feel like the studies I've seen where they've tried to send out my chart messages like, hey, you're eligible for this. People just ignore them. I ignore them when I get them from my family members. The thing that I was thinking more of is that, I don't want to anchor too much on that one clinical encounter that I had with quote unquote Mr. Smith, but the daughter was saying look, this has been such a great tool for me because I can't always attend visits. And so I rely on that. If I can't go to the visit, I'm going to pull that up. I'm going to look at the note. I'm going to look at the after visit summary. That's how I make sure that the meds are right. And so I wondered, because so many of the care management programs, including Mind at Home, they're not going to follow the patient forever and ever. Amen. They're going to follow them for a shorter period of time. Are there things that, they can help us put into the portal for the person to refer back to? It'll get tricky because if it's something like baseline cognitive status, that needs to be updated, and who's going to be responsible for updating that going forward? I thought about tying that to a Medicare annual wellness visit in the PCP's office, that's kind of a checkpoint when that could be updated. So less using the portal to connect people to care management resources, but more as a way of delivering effective things. And then when Mr. Smith goes to an ER that doesn't have our healthcare system, doesn't have our EMR rather, that his daughter can say, well, look here, I can pull up. This is what his PCP said is his baseline cognitive status. Is that helpful for you to know? I don't know. These are my musing.
Thank you. Yeah, thanks a lot. Good ideas. Okay, thank you.
We're down to the last minute. Does anyone have any last questions or comments?
Super excited that Stephanie's coming. Yay! Great talk, Stephanie.
Thanks, Lee. Looking forward to seeing you again.
Looking forward to your visit in June, right around the corner. Thanks everyone for joining today. We look forward to seeing you again next month for next Pepper Center rounds. Thanks again, Stephanie.
Thank you.